we are very fortunate to have Dr. Sciortino present to us today information regarding his Superpath hip replacement. He is the only physician in the St. Louis area that is doing this procedure. Many of our therapists are seeing some of his patients now, and as you know, it allows a great deal more flexibility with rehab, a little bit more aggressive rehab, and we can learn a lot by what he's going to tell us today. So he's going to give us this presentation, probably leave a few minutes for some question and answers at the end. I know my staff needs to get back across the street about 1 o'clock. So, Dr. Sciortino, I thank you for being here.
All right, thanks. Everybody can hear me pretty well with this? Okay. As you know, my name is Dr. Robert Sciortino. I'm an orthopedic surgeon, and I've been here at St. Luke's for about 5 years now. And I'd like to talk to you about this Superpath total hip procedure that I've been doing. I started doing this about 2 years ago. I sort of kind of almost did it sort of kicking and screaming initially. They were talking to me about this new approach that you didn't have to dislocate the hip. And I was kind of like, that's crazy, that's insane, that's got to be impossible, that'll never work. And then they twisted my arm until I actually went and did a cadaver lab about it, and I kind of talked to a surgeon who was doing it. They flew somebody in, the company flew somebody in, and I realized that, you know what, this actually might work. So I started doing it about 2 years ago, and it's been working very well. So I'm going to go over how things. Can people see this? Is there any way we can dim these lights? I don't know how well you can see that. That one. All right, that's a little better. You all see that okay? All right, good. So first off, what I'm going to do today, I'm going to talk a little bit about arthritis in general. I mean, I think you all know pretty much about arthritis, so I'm not going to go on that. I'm going to talk then about hip replacement in general, and then in particular about minimally invasive hip replacement, because you hear that a lot. You hear that term talked about, and what do we mean when we talk about that? And then I'm going to talk a little bit about the Superpath procedure. We're going to kind of describe it and how it works, and I actually have a little animation type of thing that may, I think, help you all understand a little bit better about what we're trying to do. And then I'm going to talk about some of the results, and in terms of some of the studies that have been produced. Actually, not a lot has been produced because this procedure has only been going around for about maybe 5 years or so, max. And then some of my own results and what I have found in my impressions of the procedure, and we'll also talk about a case study. So what causes this pain? Well, some of the things that cause pain, I mean, arthritis, osteoarthritis. That's kind of the main thing that I see that we're doing total hips on. There's also post-traumatic arthritis. People who've had hip fractures or other type of trauma, acetabular fractures, can then go on to have arthritis. There's rheumatoid arthritis. I see that. I don't see it nearly as much as we used to, because I think our rheumatology buddies are doing a lot better in treating these things medically, so they don't really progress to this end-stage rheumatoid arthritis. AVN is something that we see a fair amount of, avascular necrosis, that then can lead on to arthritis. And I've seen a few of those. Paget's disease can cause problems, lupus, and traumas, hip fractures, things like that. Pubic fractures can also cause hip pain. But we're going to really focus on arthritis. Now, not every patient that comes in for hip pain needs a hip replacement, obviously. And you guys probably know this more than I do. You see this stuff all the time. A lot of times lumbar spine issues can cause hip pain. Sciatica, spinal stenosis, disc herniations, things like that. That can definitely produce a hip pain. Sometimes we see knee injuries that can then produce hip pain, and vice versa. And I know people have seen that. I saw a lady a couple of years ago, actually 2 people in the same week, that were complaining of severe knee pain. One of them had a knee replacement and had all kinds of, and came to me for painful total knee. And so I looked at her, and she was in a wheelchair. I'm like, what's going on? Because the knee looked fine. And then I actually took the time to examine her hip, and she had terrible arthritis of her hip, and nobody had really examined her. So that can do. Now, there are other type of hip problems like sacroiliac joint issues, piriformis syndrome. That's a condition that I didn't really believe existed until I got it. Trochanteric bursitis can certainly cause problems. AVN, we talked about fractures, and even stress fractures that don't even show up on the X-ray. So we always have to kind of keep an open mind when we're seeing a hip pain and not just jump in to say you need a knee replacement. So what is arthritis? It is inflammation of a joint. itis, inflammation, arthritis, joint, okay, obviously. There's a whole lot of different diseases that can cause these type of things. Some form of arthritis affects maybe as many as 50 million Americans. The two most common ones, again, are going to be osteoarthritis, also known as degenerative joint disease, and rheumatoid arthritis. So osteoarthritis, also called degenerative joint disease, it's the most common thing that I see by far. It's estimated to affect maybe 27 million Americans, and as our population ages, the baby boomers kind of grow up and get older, it's going to get even more. It's generally thought of as kind of a wear and tear condition. You know, nobody really knows what causes it. I mean, there's probably some type of genetic predisposition to osteoarthritis. Sometimes it's from trauma, from injuries, maybe some developmental disorders or congenital disorders of the hip, let's say, that can then lead on to arthritis. And then again, that can result in some pain and stiffness. Here are some x-rays. This is a fairly normal looking x-ray with a fairly nice normal round head and the acetabulum, and the space that's in between the femoral head and the acetabulum is occupied by cartilage. This is a fairly normal, I think that might be my hip. I'm not sure, but I had some old x-rays. I think that's it. And then this is an arthritic hip, again, and I think that's my mom's hip. But, you know, you can see the resemblance. In any case, there's a lot less space there. There's no space. There's big bone spurs. Sometimes there's the subchondral sclerosis, and there may even be little cysts in there. So those are the things that we look for when we're looking at an x-ray for arthritis. So hip replacement, total hip replacement. That's a procedure that's been around, you know, probably since the 60s, since Sir John Charnley kind of came up with this idea years ago. And his idea was to use bone cement, which actually was used for dental procedures, and use that to cement the prosthesis to the bone. It's been very successful. Millions of hips have been implanted throughout the last 40, 50 years. And as our population ages, we're doing more and more of these. And we're also seem to be doing it in a lot younger people. So people in their 40s and 50s, it's much more common to these. When I was in training, we would never do it in someone below 65. We'd say, well, just have to suffer until you get to be 65, and you know, then you'll do it. So, but now it's becoming much more common in younger people even. So there's approximately maybe 300,000 or more performed in the United States every year. As I said, this has been going on since the 60s. And what it does is the hip implant, it sort of replicates the anatomy. There's a ball and a socket type of thing. And these are implants of a total hip, a typical total hip. They're composed of the acetabular shell, which is a metal shell. It usually has a rough coating on the outside, a porous coating, so that it's impacted in the bone, and the bone actually grows into it. These are typically made of titanium. Then there's usually some type of a liner, and the most common thing done is ultra-high molecular weight polyethylene, which is a plastic thing. Nowadays we use cross-linked polyethylene, which has a much more better wear characteristic than the old ones. Now there are other bearing surfaces. Metal on metal is something that kind of used to be done. It's pretty much fallen out of favor in the U.S. because there have been some problems with that. And there are also ceramic bearings that are occasionally used. But in my opinion, still the gold standard is the ultra-high molecular weight cross-linked polyethylene. The femoral head is what's attached to the femoral stem, and that typically is made of cobalt chrome because it does have a better wear characteristic than titanium. Titanium heads don't really work very well when used as a bearing surface. And then there's the femoral stem, which most of the time, in fact, essentially all the time, is in my hands a press-fit stem. In fact, we implant it without cement, and it also has this rough coating on the outside of it, this porous coating that helps the bone grow into it and onto it. And usually these are also made of titanium, but some of them are made of cobalt chrome as well. So this is basically what it looks like when implanted. I mean, again, we have the normal hip and acetabulum, and the metal titanium shell gets impacted directly into the bone with a little plastic liner that you can see here. And then the femoral implant gets impacted directly on the inside of the bone. We actually remove the entire femoral neck across here, and this is kind of what our goal is. Now, the traditional total hip procedure, again, through a posterior approach, is probably one of the more common. It can be done, there's several different approaches to a total hip that people can take, and it's kind of surgeon's choice as to which one they sort of do, but probably one of the more common or most common is the posterior approach, where we make an incision that's centered around the greater trochanter, usually 6 to 8 inches, you know, depending on your surgeon. We dislocate the hip, and that's done by rotating the femur 90 degrees. And so we pop the hip out, and then we remove the ball part. We actually saw the ball off so we can see down into the acetabulum. And then we use these reamers, which look like this, kind of like a little cheese grater type of thing. We kind of ream the acetabulum out to where it matches a perfect sphere, and so we can implant our acetabular component. And then we implant the femoral component, again, either with cement or with a press fit type of stem that goes inside there. Then we basically put everything back together. And that's sort of the traditional approach. So in order to do that, for example, with the posterior approach, we have to do a couple things in order to dislocate that hip. We have to cut the short external rotators, including the piriformis, the gemelli, the obturator internus. They have to really cut. And sometimes in the old days, we even used to cut the quadratus femoris. And we have to actually cut that capsulotomy. We have to actually make what's called a T-shaped capsulotomy, meaning we have to cut across the capsule, cut across the ligaments at the base of the femoral neck. And that's so we can get the whole femoral head out of the acetabulum. In addition, there are some blood vessels around there. Whenever we kind of dissecting back there, we always used to get little bleeders, and you know, we coagulate them, and then they keep bleeding. We have to hold the leg up in a dislocated position while we're working for the majority of the procedure. So, you know, some of the problems with that is, well, for one thing, it's a little bit more extensive dissection. So again, we're going to have more pain. We're going to have more bleeding from that, and maybe occasionally need blood transfusions. And then there's the whole thing about the hip precautions, the dislocation precautions, because you have to dislocate to do the procedure, then you put it back in. Then you have to do things to prevent it from dislocating afterwards, and you're all familiar with that. We always tell the patients, don't cross your legs. You can't ever cross your legs. You can't bend past 90 degrees. Use the abduction pillow for the first months, and then use a regular pillow. You know, so you know, there are some problems, and there are, you know, it's not real common to have dislocations of the hip, but I mean, I'm sure we've all seen them. I've certainly seen them in the past. The other thing, rotating the leg like that, it sort of twists the femoral vessels, and so I think that twisting of the femoral vessels can maybe slow the blood flow or the blood return, and maybe have more of a problem with blood clots and things like that. So because of some of the potential problems and because of, you know, patient demand, people came up with the idea of doing, let's see if we can do some a less invasive procedure. I mean, that's in general. Surgery has been becoming less invasive over, you know, years and years. I mean, things we used to do big open incisions, now we're doing arthroscopically. So there's been a general trend towards minimally invasive procedures. So the idea is, well, can we do that with hip surgery, you know, and use special instruments, maybe make smaller incisions? So can we do this with less muscle damage? So there's basically a few different approaches, but the main ones are the anterior minimally invasive approach. And there are also the posterior minimally invasive approach, and I'll talk a little bit about both of those. And then there's a Superpath technique, which is a little different, and we'll talk about that too. That's why you're here. So anyway, the anterior approach initially was a 2-incision technique, where you approach the hip through the anterior aspect through what's called a Smith-Peterson approach, with kind of a small thing you could see in the cup. And they actually used to do a separate incision in the back, so it's kind of almost negating your whole small incision because they had to do 2 incisions. They would put the femoral component in almost blind, you know, with fluoroscopy. So one of the problems with that was that it was hard to control the rotation, and it's hard to see the rotation even with fluoroscopy, because that's one thing that, you know, fluoroscopy is not real good at. So someone came up then with maybe doing a 1-incision anterior approach, and you need a special table that's cost hundreds of thousands of dollars, and they actually still have to use this traction table to actually dislocate the hip. They have to pull it and hyperextend it, and in order to do that, again, you have to cut all these muscles in the front part of the hip. So I think that's almost negating the whole point of doing a minimally invasive procedure, because you're still having to cut all these anterior tendons. Yeah, they can do it in a small incision, but you're still dislocating the hip. The other thing, and again, I've never done an anterior mini approach. I mean, I've seen it and read about it and this and that, but from what my understanding is, it's a lot more difficult. At least I think it's more difficult than what I'm doing. It takes longer. There's more of a sort of a learning curve to this thing. The first few dozen cases of this can be kind of difficult. The people who initially came up with these approaches all reported their great results, but pretty much all the follow-up studies have shown a much higher complication rate than with regular total hip replacements. And there's also no bailout procedure. What I mean by that is, with my approach that I'll tell you about, if I have a problem, I can always do a regular posterior approach, and I'll explain why later. But if you're doing an anterior approach, you're pretty much locked into that anterior approach, and you have to do that anterior approach in period. You have to just struggle and do it. So that's why a lot of people who do the anterior approach, they do it, but they say, well, you're not really a candidate, so we're not going to do that on you. So that's not been a problem for what I'm doing. And then there's also the posterior mini approach, and that's something I did do actually before I started doing the Superpath approach. And it was, I was actually doing something called the Path approach, which is part of the Superpath approach, and I'll talk about that too. But the idea was to do it in a little bit smaller incision and maybe not cut quite as many muscles. But the bottom line is, you still had to dislocate the hip. You're basically doing the same approach, you're just doing it through a smaller incision. So you still had to dislocate the hip, and there's still all the same problems associated with that. Still had to do all the other things. So the Superpath approach, it stands for supracapsular percutaneous assisted total hip. Okay, the difference is the hip is never dislocated to do the procedure. We keep it right in the socket. We never have to cut all those capsules. We don't have to cut across the ligaments or the capsule that's holding it. We make an incision in it, but we don't have to widely cut it open. We don't have to cut as many of the muscles. Sometimes we don't cut the piriformis or any of the other external rotators. We do have to use some special techniques, and there's some tricks to doing this way. But we don't have to do these hip precautions because we're not dislocating the hip to do the procedure. Then we don't have to have the same type of precautions that essentially all other hip replacements will have to observe. And the other thing is, which is nice about this, is the approach that I'm doing is essentially the upper third of a posterior approach. So if I did have a problem, for example, if for whatever reason the patient was too large, or whatever reason I couldn't do it, all I would have to do is extend my incision about 2 or 3 inches down the thigh, cut a little bit more capsule, and boom, I'm doing the same approach that I've been doing for 20 years. So that's really appealing to me, in particular when if you're trying to get a surgeon to do this, or a surgeon's doing this and they're in that learning curve type of phase. You can always start out by doing a Superpath. I can't quite do it, and let's do part of the procedure, and then just do a regular total hip. So you're not losing anything to do that. Okay. So the nice thing about this is it is a tissue-sparing approach where either few or no muscles or tendons can be cut. And then we don't have to do all these hip precautions. So the incision is actually much smaller. We can do it in about a 10 centimeter incision, sometimes a little more, sometimes less, versus the 6 to 8 inch incision. But I think the really key thing is that we don't have to dislocate the hip. That's the difference. I don't care what the incision is, whether you have to make a longer incision or shorter. I care about not having to cut these tendons and not having to dislocate the hip. So because of that, the patients generally get moving faster. And I know some of you have seen some of the patients in the hospital, and I think you might think that these people do get up a little bit faster than your average total hip patients. And they don't have to worry about, crossing their legs. They don't have to worry about bending bending past 90. A lot of my patients get rid of their walker within days of surgery and use a cane maybe for a week or a couple weeks. So the recovery is much faster, in my opinion. Now I'm going to show a little animation about the procedure. I'm going to try to narrate this. There's no sound to it, so you'll have to listen to me. Let me see if this works by clicking. Yeah, okay. So, so this is the procedure. The patient is placed in the lateral cubus position, and basically the entire procedure is done with the hip flexed about 45 to 60 degrees and the leg on the Mayo stand. The incision is from the tip of the trochanter, about 10 centimeters posterior. The leg's going down that way. Okay. We put some little retractors in. We split the fascia over the G-max, and then we split the G-max in line with its fibers, so we're not cutting across anything, and that's not too much different. And then we look for the gluteus medius, and we kind of incise the fascia over that and pull that anterior. And then we see the piriformis muscles and the tendons, and we kind of pull those more posterior, all right, or yeah, towards the back. And then we insert our retractors in there. Now we make our capsulotomy, and the capsulotomy is longitudinal along the capsule here. And then we put our retractors in a little deeper inside the joint. So now the retractors are inside the actual hip joint. We put a reamer usually down. We ream down the canal, open it up a little bit with this other reamer. So we're finding the center of the canal. That's right in the piriformis fossa. And then we use this little chisel, and we actually create like a slot in the superior femoral neck and femoral head. And we remove some bone from that area. And that's what allows us to do the procedure without dislocating. We actually broach, we use our little broaches right through that slot. And then after we put the broach in, we make a cut across the femoral neck, and only then do we remove the femoral head. Now, we still have not dislocated the hip. We've removed the femoral head without even dislocating the hip. All right, so that's the supercapsular part. And now we're going to do the path part, which is the percutaneous assisted total hip. So we're exposing the acetabulum a little bit better. We put our retractors in a little deeper, put some other retractors in, so we can actually see inside the socket. So that's inside socket. The key with the path, this percutaneous, is this aiming arm. So we put that inside the acetabulum, and then we make a little stab wound on the thigh here, and then we take this cannula, we take this metal awl and put it all the way down until it goes in the acetabulum, and then we leave this metal cannula. Then we put our little reamers in through the top incision, and we run our reamer shaft through this incision, and that's how we do the reaming. So we ream that up till it gets to be the size that we want, and then we actually take the implant, and then we impact that into place, and that's got that porous-coated implant, and we hold it in proper alignment. We impact it right in through the cannula, okay? Then we take out the little inserter device, kind of remove that, and we can put screws in now if we want. Now we put a little liner, a little plastic liner in, and then we put the head in that way, and then the neck goes in the stem, and then we just sort of mate the two together inside the patient without ever dislocating the hip. And that's how we do it, basically. That's the procedure. Then we just put the final implants in. So that's the secret. That's why this works. That's why we can do this without ever dislocating the hip. Here's a case. This is a patient of mine, 62-year-old guy. He's had pain in his hip for years, pretty bad looking x-ray. I mean, it's bone on bone. There's no cartilage left there. He's had anti-inflammatory medications. He's had cortisone injections. It's interfering his life. He can't bowl anymore. He's a volunteer here. He's around here all the time. And actually, he was referred by a physical therapist. Hey, I've heard about this new thing, so why don't you look into it? So he talked about it, and we decided that to do surgery. And this is his post-op x-rays. You can again see the acetabular component here. I always secure that with at least one screw up in the superior dome. The polyethylene part, this is the ball part and the stem that goes in there. So he was done on a Friday afternoon. Post-op day 1, after a couple sessions of therapy, he was walking 400 feet using a roller walker. He was able to get in and out of bed. He was able to go up and down stairs, and he went home day after surgery. At 1 week, he called up and says, I don't want to do outpatient, or I don't want to do home therapy. I mean, I want to go see my therapist. He wanted to go see the therapist that referred him. So we were like, okay. So he wanted to go to outpatient. Saw him at a month post-op, and he was walking perfectly well without any limp. I mean, not using a cane, not using anything. And if you don't believe me, then just listen to him.
I had the Superpath hip replacement done in January. I I have really bad arthritis in both my hips. And when I would go bowl, some nights I could bowl well, some nights I could not bowl very well at all and everything because the pain was so bad. And then when I would go home at night, I could not sleep because the arthritis was so bad and stuff. I talked to some of my friends who I bowl with who had had hip replacements, and they said, whenever you come to the point where that your hips hurt you so bad that you can't sleep at night, then you need to get your hip replaced. I happened to be going to a physical therapist at the time here at St. Luke's. Her name is Amy Sciortino, and I asked her about hip replacements, and she said, why don't you look into the Superpath, P-A-T-H, hip replacement, and it's done by Dr. Sciortino. And after the surgery was done, they had me up the next day on Saturday, and I was able to walk up and down the hallway. It was, everybody was amazed. The whole family was amazed how quickly it was, the recovery was. The hospital and the staff were excellent. I mean, they really helped me out a lot. Dr. Sciortino and his staff was also excellent in helping me to go through recovery. And then especially the physical therapist, Amy, was also excellent at helping me recover and everything. I would recommend it to anybody.
So, you know, I mean, he's a great patient, but that's fairly typical. I mean, most people do pretty similar to how he does. So, the only other things I want to talk about is a little bit about the results of the Superpath technique. There's not a whole lot of literature out there. This is one of the more recent articles where they looked at, it's a place where they did 3 centers, and they looked at things like the readmission rate, discharge rate, transfusion rate from 3 different surgeons who are all using this technique. This is their data, and you're not expected to memorize this, but basically what they're looking at, there are 3 different sites, total of 479 cases. They looked at the 30-day readmission rate, which apparently is some Medicare thing. They looked at the discharge status, where they went home to a skilled nursing, home with home health care, or a rehab center. I don't know why they did it that way, but they looked at the transfusion rate, and they also looked at the length of stay, and then also complications. So, I mean, the complication rate was pretty low. I mean, handfuls of complications in any of these. So, again, not any higher than with traditional hip replacements, probably less. Summary, basically, their average length of stay at all 3 centers, taking all comers, was 1.6 days, which is pretty good considering most of the time a total hip replacement, at least here anyway, our patient population is going to be here 3 days, sometimes more. Their readmission rate was 2.3%, with, you know, they sourced an average of about 4.2% for total hip patients from a study that was done. Their transfusion rate was actually pretty high. One of the centers had an incredibly high transfusion rate, which I think his criteria for transfusing is a lot higher than ours. So I'm not sure what our transfusion rate is here or what our thing to compare that with. But the other thing is 95% of their patients were discharged home, and again, taking all comers. 67% of the traditional hip replacements, looking at historical controls, go home. So it, you know, definitely compares favorably to, or in a lot of ways better than with the traditional hip replacements. Now, my own Superpath experience, I began doing these in May of 2013, and for the first at least 6 months to a year, I probably, you know, I barely even told the patients that we were doing anything different. In other words, I'd say, oh, we're doing a new approach, it's a little less invasive, but I didn't make a big deal about, you know, oh yeah, this is a new thing. Because I wanted to see what happened. I wanted to see, you know, how they did, all right? The age range, the youngest patient I'd done is 21. The oldest was 89, which was a fracture. There are, at that time, 44 cases. They're probably more like 48 or so now. 13 of them were for femoral neck fractures. You can use the same procedure with the femoral neck fracture, you just don't do the acetabulum. And the 31 are for total hips. Of those, 4 were AVN, the rest were arthritis. Again, these numbers are a little higher now. So the number of cases, 31. My average length of stay for all comers was 2.4 days. So it's less than 3, which is the typical for total hips. In looking at my total hips, 0 readmissions, 0 transfusions, 0 DVTs, 0 infections, 0 dislocations. I did have 1 intraoperative fracture. I don't feel that that was related to the technique. It was somebody who had some osteoporosis and for whatever reason developed a little crack. So that's, I think, my only real complication that I would say. And also my discharge status, 27 of those went home and 87%, in other words, went home, all right? I thought, well, that's okay, but I thought it should be better, you know, in terms of length of stay and things like that. So I kind of started looking at that a little more critically. And that 2.4 days includes a couple of outliers, one of which, you know, somebody had to be admitted to the ICU because they had some atrial fibrillation, new onset, and were on a cardioid drip and wound up staying for 7 days. Another person who had some lung problems and had trouble breathing and such, some pre-existing lung problems, and then developed some problems, so he wound up staying for 5 days. So if you subtract those 2 cases, then my length of stay was actually 2.2 days, which is, again, seems a little bit better. But I thought it still could be better. So I kind of changed my protocol in about August of last year, 2014. I started doing some different things to try to see if I can improve the pain of my patients and get things moving faster. And if I look just since August, my length of stay went down to 1.6 days. So what I basically started doing in about August, I started doing a sort of a new protocol, which added some new things to kind of help control the pain, which I think has really helped. One thing is use something called Exparel, which is a long-acting local anesthetic, sort of like a timed release anesthetic. So that's injected into the soft tissues around the hip, and that really seems to help the post-op pain on day 2 and day 3, you know, and later in day 1. I used to just use a local sort of cocktail with Marcaine, and they would do great in the recovery room, and overnight, that first night, they were having no pain. And we'd see them in the morning, oh, I'm not having any pain. And then we'd leave, and then they'd try to get up to therapy, and then their hips started killing because the local wore off. Well, the Exparel really doesn't start working until like the first morning. So then their pain is actually much better the day, and I'm getting, you know, pain scores of 0. I mean, a lot of people. I started putting them on Celebrex preoperatively, just empirically, and then keeping them on Celebrex while they're in the hospital. I started using gabapentin, Neurontin. I'm not sure why, but it seemed to work. It seems to help with some sort of neurogenic mediated pain. I put them on a fixed dose of OxyContin just for the first 24 hours, a small dose, 10 BID, just to have a little bit of opiates on board without snowing them. And we also put them on Tylenol around the clock for the first 24 hours. Maybe sometimes give them an IV. I don't know that it's the IV. The other thing I do is the tranexamic acid. Tranexamic acid is a fibrin inhibitor that basically decreases blood loss. It's being applied to a lot of orthopedic patients, and it seems like it is really making a difference in terms of blood loss. And I think because we don't have as much blood, we're not doing as much swelling into the soft tissues and not as much bruising. And I think that's also helping with pain control. So, you know, since I started this new protocol, I'm not seeing those patients who are having pain all night, and then you come in the next morning and they got the wash rag on their head and they got the barf basin next to them because they just got a huge dose of morphine and they've been barfing all night. I don't see that anymore. I don't see it. You see them the next morning, they're reading the paper and having breakfast and saying, hey, when do we start therapy? You know, and it works. So what about physical therapy? That's probably why you guys came here, okay? I'm assuming. So what I would say in terms of the difference between this is the hip precautions are generally not required, okay? That's kind of a hedge, I guess, on my part. I guess I'm chicken to really say, absolutely, don't do it, hip precautions, don't do it. But, I mean, you have to have some reason. I mean, I don't want the patient to take up yoga, you know, right away. I mean, I don't want you to start, you know, giving them like one of these deals or something. You know, avoid extreme positions, you know, especially on some of those people who are kind of hyperlax, you know, type of thing, or maybe, you know, people with maybe a little bit of elasticity. So while they're in the hospital, you know, again, we're focusing on gait training, getting in and out of bed, transfers. I think, you know, we do, with this procedure, I think we do need to do a little bit more in terms of stretching than we would think about doing for a regular total hip replacement. You know, again, that doesn't mean you're going to crank them up in 90 degrees and start externally rotating them either, okay? But, I mean, you want to maybe, you know, stretch those adductors, you know, work on pelvic tilts, some glute sets, some strengthening, not really doing any resistance, but you do want to do some strengthening and some stretching, for the first couple days in particular. And then as an outpatient, I think you probably want to increase that, do a little more stretching. They talk about, beginning to add some early resistance exercises, progressing to a cane. I mean, when I was in training, I would tell people, you got to use that walker for a month. I don't want you falling. I don't want this. They don't need to. I mean, I saw a gentleman this morning. I said, well, how long did you use the walker? I said, I used it for a day. I was like, well, oh, how long did you use your cane? First week I used the cane, and then I'm fine. And he's a month out now, and he hasn't been using it for 3 weeks. So I think it's okay to progress him to a walker. It's okay to progress him to a cane, as within their own tolerance. And then, after a few weeks, after the soft tissues are kind of really healed, some people will need a little more stretching. They talk about doing some adductor strumming and doing clamshells and, really trying to build up their abductors and their strength. So what is my overall thought about this procedure compared to what I was doing? There's less pain. I am convinced. And I'm not sure how much of that is due to that new protocol I'm doing and how much of it is due to the procedure itself. I think it's a combination of things. But I definitely can see there's less pain. And again, some of you have probably seen him inpatient, may agree with me or not. I'm welcome to hear what your thoughts are. I think there's less blood loss. So far, I had not to transfuse anybody. I didn't have a high transfusion rate with total hips, but so far I haven't transfused anybody. I see less bruising. I don't see the hematomas. I don't see the swelling. I've not seen any hematomas and any problem wounds like that we used to do. So because there's less blood loss, there's less transfusion. My series is 0 for the total hips. Earlier discharge. I can say I'm sending the majority of my patients home now the first day, since August anyway. Since I've gotten better and the therapists have gotten better and they're more used to it. The nurses are now used to this procedure and they get it now. They get it that these people can go home the day after surgery. So I would have to say the majority of my patients are going home the day after surgery. They get better faster. They return to doing what they want to do a lot faster. They're going back to work in a week, 2 weeks. Some of them are not. I mean, you're not going to be out digging ditches in 2 weeks, but somebody has an office job and then wants to drive to work, okay, do it. I'm not seeing people go to skilled nursing. I had a 79-year-old, went home day 1. No need for skilled nursing. Less home health care visits. Unfortunately, for those of you who are home health, that may be bad news for you guys, but I'm finding that some of my people say, yeah, I don't want to wait around for the home health. I want to go out and do stuff. I mean, they don't want to sit at home waiting for their home health, so they want to go out to do the outpatient stuff. The hip precautions. They're not using the foam pillow anymore. They're crossing their legs. I remember having a therapist come with me, and we're on a patient his first post-op visit, and he goes, "Well, it kind of hurts when I do this," and therapist eyes go like, like that. Monday, I saw a lady. I came in the office, and she was sitting on the exam table with both knees pulled up. I can't even do it. I mean, and her arms are on her knees, like people said sometimes. So, yeah, the complication rate is no higher than it was with a regular total hip. In my hands or in the studies, it's no higher, and maybe less for a lot of things. I think the DVT rate may be less because we're not twisting those vessels. Again, I don't have a big enough sample to really say that. And it doesn't take any longer for me to do this procedure. And I've been doing it for now a couple of years now, kind of got it down. Probably the first few I did maybe took a little bit longer, but certainly now it doesn't take me any longer than a traditional total hip used to. I don't think you can say that with the anterior approach or with really any other approach. So that is all I have for you. So I don't know if you guys have to go back to work yet. It's 12:45. So hopefully if people still have some questions, I can answer them. We have a little bit of time for that. So anybody? Yeah.
So I have a patient, the one person I have a Superpath had that adductor and hip flexor tightness, spasms almost at one point.
Yeah.
Is there a reason behind that? Is it the fit of it, or is it the...
I think, well, it's because it's different than a traditional total hip. The capsule is essentially intact. We're not cutting the capsule at all. So, and we're actually sewing it back together. Whereas when you do a traditional total hip, you're actually cutting across the capsule, and although you kind of throw a couple stitches in it, you're never actually able to repair that back to the bone, So with these people, and probably when someone has hip arthritis in general, their capsule is contracted. It is probably tighter and stiffer, So even though the bone, we're removing the bone in the arthritis, that capsule is still thickened and it's still kind of arthritic. So I think that's why you have to do it. Now, when I was in training, the professor, we used to take out the capsule. You take the anterior capsule and the posterior capsule because they thought, oh, that'll have better range of motion, and we can lengthen them and all this stuff, blah blah. The dislocation rate was about 5%. So it's a little tighter, and you probably are going to need to stretch these people out maybe a little more than with a regular total hip. But I think that's not a bad thing, for their function. So, all right. Anybody else have any questions? How about right there?
You don't have a drain in on
I do not. I have not been putting a drain in on these.
So that little hole we see is that second.
That's the little, that little percutaneous cannula goes through that. So exactly, that's exactly what that is. You've seen those. Yeah, no, I stopped using a drain at about the same time I started using the tranexamic acid because I wasn't getting anything. We used to use Constivac drains where they'd suck the blood out, and it was a couple $100, and then they'd get the blood, and they'd filter, and I was getting no blood in it. So I'm like, well, why am I even bothering with this? So I stopped using it, and it's not been a problem. I've not had to do that. Yeah.
Or with a traditional total hip instrumentation, just in case?
Well, the instrumentation here is the same. You can do you could do a traditional total hip with the same instruments. There's really nothing different about it. The only thing, you have a couple extra things like the cannulas and stuff like that. Maybe you would have a preference in a different retractor, but there's really no difference in terms of the setup. All it would take to convert this into a total is just make your incision a little bit longer, and you might have to put a Charnley retractor in, but the retractors are fine for that. So you might need a couple extra retractors, but like I said, so far I have not had to do that. And like I said, Wednesday I did a guy, 350-pound, 49 BMI guy with this, and I was a little worried. I was like, today I may have to extend your, and we did have to make him a little bit longer incision than with the usual, thing. But even though the skin incision was longer, the internal incision was the same. The capsulotomy, I didn't have to cut across the capsulotomy. We didn't have to cut his piriformis. So he should have the same results. In fact, he went home the day after surgery, just like everyone does. And when I saw him the first morning, he had just gotten out of bed by himself. He was up doing shaving or something, that fine. So, all right. Anybody else? Question? Yeah, right there.
Is there anyone who's not appropriate for this procedure?
If they've had prior hip replacement, you can't do revisions through this procedure. And if they've had prior surgery, it may or may not. If, I have someone who had an acetabular fracture and has a posterior approach and a plate already, and I told him that we're going to try, but we may not be able to do it. We may have to dislocate your hip. So if someone's had prior surgery, then that could be a problem. I've had one person who I was worried about because they had such a deformity of their femoral head. They had a big osteophyte medially, and one of the things to do when you position the patient, you have to really kind of flex the hip to 60 and really adduct it as much as you can so you can get at the back. And I put him up here. I couldn't adduct him. He was stuck here. His leg wouldn't come together at all. So I was a little worried about that, so it took a little bit, but as soon as I was able to kind of, make the femoral neck cut, then it was just fine. It was no problem. So yeah, potentially if somebody's had some prior surgery, it could potentially be a potential problem. But so far I haven't had, every total hip I've done since May of 2013 has been a Superpath hip. I have not had to bail on anyone yet, including BMI 49 guy Wednesday. So another, yeah.
On your patients, are they on
That's a great question. And the answer is yes and no, depending on your point of view. Right now at St. Luke's, I am still using Coumadin as a blood thinner. All right. I don't believe personally in bridging therapy for total hip patients or total knee patients because I think the risk of hemorrhage, post-op hemorrhage, is too high. I know it takes a couple days for the Coumadin to be effective, which is why I think it's very important to use pneumatic compression stockings. The problem I see is here the pneumatic compression stockings are the ones that are attached by hoses. So what happens? The patient's in bed, then they have them on, but as soon as they get out of bed, they unhook them. So they're sitting there with their legs dependent, eating breakfast and walking and doing whatever, and they're not hooked to anything, they're not doing anything. Okay? My preference would be to have pneumatic stockings that are portable, which they make, that they can put on 24/7 and keep on 24/7. And I do send the patients home with that, because they do have a contract with someone where they, put them on and then they can send it back at some point. So my goal would be if we can get that type of thing in the hospital where they're wearing those things, I probably would just switch the patient to aspirin, 5 grains BID, because I think that would probably be as effective, especially combined with pneumatic stockings that are actually worn, but not ones that you put on or not hooked up. So they do wear them at home, and they have those, the ones that the portable ones, and you probably have seen those, and I think those are good. And what I have them do is wear them for about 10 days. Again, I didn't come up with this. That's what they do at Barnes. If you have your total hip at Barnes or total knee, that's what you're going to get. And they've got some studies that are not published yet, but I could talk about that for a couple hours too. But yeah, so yeah, I'm transitioning to the point where I'm probably going to start using just aspirin, especially on healthy people who know pre-existing problems or no history of DVTs. But I'm not quite there yet. So okay, who else had a question? Right there.
Components that you're using?
Yes.
Are they similar to the traditional, so that if you did have to stop, could you transition?
Yes.
Or are they specific to that?
The short answer is yes. I was going to bring them down. I forgot to bring a sample down. I use the exact same implant that I've been using for more than 10 years. Exactly the same. There's no difference in the implant that we put in. There's a slight difference in the instrument in terms of like the broach is like the main thing that we put down. The broach has to be straight. And it just so happens that the implant that I have been using for 10 years or more works really well with this system. I mean, it's like it's designed for it, even though it was designed 20 years ago. The Zweimüller stem's been out for 20 or 30 years, probably. In Europe a lot. It's been the one I use, the one this is based on. So yeah, these implants are exactly the same. So we're not changing anything there. Sometimes with these anterior approaches, that's one of the things in orthopedics, like this new thing, like using shorter implants. Well, the reason they came up with that is because it's hard to put in a traditional implant through an anterior approach. So they made these little tiny micro implants where they're a lot shorter and stuff. You don't need that. You can basically put any implant in through this, provided they have the right broach. So, all right. Anybody else? Questions? Go ahead.
Or is it just that it's a smaller incision?
It is the capsulotomy is the reason. It's maybe a little bit more superior, but really not different than the superior part of a posterior approach is what it is. Because again, with a posterior approach, we're going just posterior to the gluteus medius and minimus, and our capsulotomy is usually in line with the piriformis tendon, which is basically what this is. But with a posterior approach, in addition to going to the piriformis, you're also going around the femoral neck this way and around the femoral neck this way. So you're actually making what's called a T-shaped capsulotomy. Instead of just an incision and then putting retractors in like this, you're cutting it and then cutting across and then flapping the whole thing open like a barn door. And then, everything comes out. And then you can kind of sew it together a little bit, but you really can't reattach it to the femur. With mine, I don't detach it from the femur. So that's the difference. That's the stability. So, all right? There.
Does the fracture have to be like above the trochanter or kind of?
Correct. You can do this on a femoral neck fracture patient. There's two, not on a shaft or an intertroch fracture. Those you'd basically repair. You could do this on the type of fracture that you would do a partial hip replacement on, which essentially are femoral neck fractures. So as long as it's in the intracapsular at the femoral neck, then you can do this procedure. If it's an intertroch fracture or a shaft fracture, you would repair that with a plate or a nail or a screw or however you like to do that. So, all right. Anybody else? Right there.
skin, or does it puncture other soft tissue?
It goes all the way down to the capsule. I mean, there's a big sharp kind of pointy awl, and that cannula is around it, and you put the awl down, and it's a blunt awl. It's not real sharp, so it goes just posterior to the femur and kind of anterior to all the nerves and blood vessel kind of structure. So it kind of hugs the posterior femur, and it kind of just goes bluntly all the way and pierces the capsule. So you have a conduit from the skin all the way down to the joint. And that's where you put your reamer shaft, and that's how you impact it and all. So, okay? Right there.
One more. Are you working with any of the other orthopedics here at St. Luke's to do this? Are you?
They have not shown any interest, which is fine with me.
Right.
Okay.
What is your expected longevity with this approach?
It should be no different from any other approach. I'm using the exact same implants that I've been using for, 10 years. And, this newer highly cross-linked polyethylene should have a more longevity than the old stuff that we used to use. I used to quote people, and I still do, there's about a 90 to 95% 15-year survival on total hip implants. And people say, oh, it's going to last 15 years. Well, that's not what that means. That means of the implants done 15 years ago, probably 90, 95% are still functioning. And they're not all going to fall off the cliff after the next year. They're going to, probably gradually subside over time. And the reason is they've done sort of estimated wear rates and of, simulators and things like that. And probably, again, I might have to get some of the company engineers probably would be able to tell me if this is true or not. But my old thought was that the old polyethylene that we used to use, the wear rate was probably somewhere between 0.5 and 1 millimeter per year. Maybe. I don't know if that's, maybe something like that. So that means in 10 years, you could wear between a half a centimeter and a centimeter, right? I mean, and there's only about a centimeter of plastic, maybe. Okay, so that's why you get 10, 15 years, it's going to wear out. Now, with the cross-linked polyethylene, again, I probably need to, maybe I'm lying to you, but what I've been told or heard is that the wear rate's probably more like 0.1 or 0.2 millimeters per year. So that means to wear a centimeter, it's probably going to take 50 years, 100 years? No? I mean, again, maybe I'm lying about this. I don't know. I'm just making stuff up. But it's going to take longer to wear the stuff we're using now than the stuff we used to. Now, I can't say, oh, yeah, it's going to last for 50 years, because we don't know that, because it's only been around for 10 years or so, the cross-linked polyethylene. So it's a long answer. The answer is I don't know, but I think it's going to be, it should be no worse than the total hips. And again, the alignment I'm being able to put in these things is exactly the same. I mean, with the anterior approach, some people have a hard time getting it in just right because they can't see as well. I've had, the alignment of my prosthesis is great. I mean, it works. So, yeah. Who else? Listen, I haven't been over here yet. Let's go ahead.
Have there been any research on more aggressive therapy initially with the Superpath?
I don't know. I mean, because it's so new. And I'm calling, the guy who invented it, saying, hey, where's your therapy protocol? What do you do with these people, And so I think it's something that we don't know. I think that he is, probably Jimmy Chow has a therapist that he works with that's working with stuff. So, I mean, that's a great question. I don't know the answer to that question, though. So, okay. Let's see. Who else had one back here again? Yeah.
I just wondered, when you do a revision, is it typically just replacing the polyethylene, or do you have to replace?
It can be.
All
It can be. The theory was, and that's why the acetabular component and the femoral component are modular. The bearing surfaces are modular. So the theory is that you should be able to just pop the plastic out, pop a new one in, take the head off, put a new head on, and you should be good to go for another 15 years. And that's the theory. That doesn't always work out that way, because sometimes when people get wear, they get a lot of polyethylene debris, these little microscopic pieces of plastic. And your body sees that as a foreign body reaction, and it tries to use your macrophages to eat it up. And they can't digest it because it's plastic. And so they die, and they release the cytokines, and that kind of diffuses into the tissue, and then you get what's called osteolysis, where the bone kind of starts going away. And that usually, or a lot of times, will cause the components themselves to become loose. So sometimes that happens. And I have been able to do it. In fact, a couple weeks ago, I had 2 of those in 2 weeks. We were able to actually just take out the old plastic, because it had worn essentially through, and there was a lot of plastic reaction. And in one case, or actually both of the cases, I had to actually cement in a new bearing surface, and patient should be good to go. So yes, sometimes you can just do what's called a poly exchange, but other times there's too much damage and the prosthesis is loose, and basically it's not that hard. You can reach in, well, it's hard, but you reach in there, you yank on it, see if it comes out. If it comes out, then you have to replace everything. If it doesn't come out, you just keep it. So, all right, pretty simple. Yeah.
The joint surfaces on the old total hip replacements the same as the Superpath, you're saying?
Mm-hmm.
It appeared like the old one was like a ball, metal ball that you had in there. And when you were showing the surgical procedure, it looked like you dropped in like a half moon kind of spear.
Yeah, it's the same. It's the same. Those were the trial components on the little animation thing, so they look more plasticky. They didn't have the shiny type of thing. But basically, you sort of do it the same way. Once you put in the final polyethylene in the acetabulum, then you drop the hip ball into the acetabulum, which is metal. And then you put the neck of the prosthesis into the head. That's the difference. Because the old way is you put the head on and then you push the whole thing in. This way you drop the ball into the cup and then just kind of work the neck into that prosthesis like that.
Does it tend to be a tighter fit?
I mean, I think because you're not removing the capsule as much, it's harder to like make them too long, which is good because you don't want to over lengthen people. So yeah, it does feel a little tighter. And what I usually do is as soon as I get the trial in, or the main thing is I put my finger in the capsule, anteriorly, and I have them flex the hip up, and then I have them, or actually posterior, I put my finger in there and flex the hip up to 90 degrees and have them start externally rotating them. And if you've ever been on a total hip, or somebody, usually what happens is, you start rotating it, and then it starts coming out, and then the surgeon always says, he'll never get in that position, ha, 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 and then you put it back in and you close, What happens when I do it is I put my finger in there, and they start rotating it, and it just stops, and my finger starts hurting because it's getting squeezed by the capsule against the prosthesis. So it's not like he'll never get in that position. It's like he can't get past that position without ripping his capsule. So that's why it's more stable. Okay, who else? Way in the back. Oh, I didn't see you back there. Dark back there.
Are you the only surgeon in St. Louis doing this technique?
Yes, correct. There's a couple other people who have tried it on a case or two here or there, but I'm the only one who's doing it routinely every case. In St. Louis, I think in Missouri. Is there anybody in Kansas City doing it? So, yeah, I got somebody in Kansas City doing it now. So, anybody else?
Do you or can you compensate for like length discrepancy with these surgeries?
Yeah, you can within reason. If somebody is a centimeter or two short, you can lengthen them up. Okay, but if somebody is like super short, like if somebody had developmental dysplasia of the hip and their acetabulum you're probably not going to do this procedure on them. It's not going to work. If you have to relocate their acetabulum, there's just no. You can probably lengthen somebody a couple of centimeters, but if they're like 3 or 4 centimeters, you're probably not going to make it. But that's probably true with any total hip, really. So yeah, you can make up a centimeter or two, but if somebody's got that's one of the things you probably couldn't do is like somebody had a real bad CDH or developmental dysplasia of the hip as a child, you may not be a candidate for this procedure. That's something else I probably should have said. So, anybody else? I guess we're getting close. Yeah, it's past 1, so I think we'll probably stop here. And if you have any questions, I'll be around a little bit.